And so now I am pleased to introduce our second speaker and our second part of our building a specialty lens practice. And this, I love this slide because it's showing all of our amazing doctors on the panel. So proud of each and every one of the doctors presenting today. Very, very well accomplished and just really good friends as well. So our next speaker is a good friend of mine, Dr. Melanie Frogrozo. Dr. Frogrozo completed college at the University of Texas at Austin, and she completed optometry school at the University of Houston. And this is so interesting to me, and I hope that Dr. Frogrozo talks about this when she is going through some of her lecture, but she graduated optometry school in 2008, and then she went and practiced in a commercial setting in Kansas, and then she decided she wanted to do specialty lenses. So then she went back and did a contact lens residency in 2011. So Dr. Frogrozo and I actually completed our residencies during the same year. But this is just another path that Dr. Kramer and I were just talking about. There are no one path to getting to specialty lenses. Look at Dr. Frogrozo going from getting out of school, practicing a few years, and then going back and then completing a Cornea contact lens residency. I just think that is so amazing. And Dr. Frogrozo owns Alamo Eye Care, which is in San Antonio, Texas. She does lots of different things, not just specialty lenses, but she does routine eye care, pediatric contact lenses, glaucoma, diabetic exams, dry eye. And she just has a list of incredible accomplishments. She's a fellow of the American Academy of Optometry and a fellow of the Scleral Lens Education Society. She's also a member of the AOA, the Texas Optometry Association, and the Ocular Nutrition Society. So super excited to have Dr. Frogrozo. Thank you for donating your time today to educate all of our guests. And with that, I will turn it over to you, Dr. Frogrozo.
Thanks, Stephanie, for having me today. I'm really excited to share my story. Just like Dr. Wu was mentioning, I have a little bit of an atypical path. I graduated optometry school, and after I graduated, I wanted nothing more than to just practice and never, I didn't even think about furthering my education in any kind of way. I just wanted to get a job. I was ready to start my life and be done with school. So I moved to Kansas City, and the first opportunity that I got as a practicing optometrist was within a commercial setting. I worked next to a lens crafters. I was hired by an optometrist who subleased a lens crafters, and I worked there for 3 years. And I knew right away within the first year of my practice that that I wanted something more. The practice was very fortunate in that they practiced medical optometry. They had an OCT. They had a fundus photographer. They had visual fields. They also had a special macular visual field. So they really focused on medical optometry. So I got to practice those, but being within the setting that I was in, I noticed that most of my patients I was referring out, and the optometrist that owned the sublease, kept his contact lens practice. He was able to dispense and actually sell revenue packs and did some specialty lenses, but I noticed that the patients that kept on coming back year after year and were so grateful were my contact lens patients. So I kind of, within that year, I knew I wanted to go back and do, a residency, because most of my patients I was referring out because I didn't know what to do with them, with respect to disease. But I didn't notice that my contact lens patients that I could help. But when I got to these difficult contact lens patients, I had to refer them out, and I didn't know what to do with them. So my contract within that practice ended after year 3. And within that last year, I decided that I wanted to do a cornea and contact lens residency, because the focus of that was I knew I was going to finish my residency, and I wanted to go back I knew I wanted to matriculate back into private practice at some point. and I was going to see comprehensive care, but I wanted to know how to take care of that special population base that I knew that was going to keep on coming back. So that's why I decided to do a cornea and contact lens residency. It made sense because I'm from Texas to go back to Houston. My parents were there, so the transition was really easy. Living with, staying with my parents when my husband was in Kansas City, so it was very difficult. I made a very difficult decision to be separated from my husband, states away to pursue this, but it's something that I felt incredibly strongly about. After my residency, I felt it was an immersion where I knew, how to recognize these patients, maybe what to do, but there's still a lot of self-learning. And even now I continually learn, and I go to meetings. I ask, my friends for help, like Dr. Wu and Dr. Kramer and Dr. Morrison, and I still shadow, and I actually travel to other doctors' practices out of my city. Actually, 3 weeks ago, I went to go learn from a really good friend of mine in Dallas who has a much larger specialty lens practice than me. I'm still continually learning, so that never stops. If you want to see this special population, if you invest in it, your time and your efforts, they will come. The patients will recognize it, and then also your colleagues around the city and around the area will recognize your passion for it, and your practice will build. So after my residency, I was fortunate enough to get offered a position at the University of Iowa Department of Ophthalmology and Visual Sciences with Dr. Christine Sint. And I was there for almost a year and a half, where I got to learn from, in my opinion, one of the leading experts in the field and in the world on specialty lenses. So I got to learn directly from her. And with that knowledge, I felt more confident, still learning, until this day. But I wanted to go back to Texas. I'm from Texas. I'm a Texas girl. So we were looking to move back to Texas to be near to my family. So we chose San Antonio because I was familiar with the Hill Country, and that's where I graduated. I graduated undergrad. So I actually bought an established comprehensive practice. They saw no specialty contact lenses. It was mostly comprehensive eye care with an emphasis on glaucoma, because the doctor who owned the practice at the time really loved practicing glaucoma. So I inherited a bunch of glaucoma patients, which I'm fine with seeing. I'm glaucoma certified here in Texas, and I enjoy seeing glaucoma patients. And as you actually start seeing specialty contact lens patients, or patients with very sick eyes in general, you'll learn very quickly there's never just one thing wrong with the eye. Just like Dr. Wu was saying, is that a lot of times these patients have, high refractive errors and retinal concerns. And, my referring doctors, my surgeons, don't necessarily want to, see these patients back for glaucoma evaluations or medical examinations, because they want to do surgeries. So they're happy for me to take care of their retinal health. So I enjoy doing that. So when I came back and I bought this practice, I thought, well, I'm excited to offer comprehensive care. And if a specialty contact lens patient comes in, this is going to be great. I'm going to know how to handle it. But I was out in practice for 3 years already, and I know that those are far and few in between. I'll probably see one a month if I'm lucky, and I'm going to know how to battle it, and it's going to be awesome. And I'm going to have this thriving comprehensive practice in San Antonio, Texas. So that's where I started. And as I started my practice, I found that there was such a need for this type of care. Is that there are doctors in the area that do practice specialty contact lenses, but not at an incredibly high level like I had been trained to, or how I was aspiring to practice. So my practice grew incredibly quickly, and filled a lot of my schedule filled with specialty contact lenses. And I had to hire another associate. I opened my practice in 2014. And at the end of 2015, we were busy enough that I could hire another associate who was going to take on more of my comprehensive care. I'm still seeing comprehensive patients, but I hired our second associates to take on to that because my schedule filled up so quickly with specialty contact lenses. And then we were able to increase our space. I started off with 1,500 square feet. We're now at 4,000. We had a shelf space, fortunately, that we could grow into. So now we're at 4,000 square feet, and we have 6 exam lanes. And I have another associate who is now I'm starting to teach specialty contact lenses too, because of my practice has grown, and I need you can't do it all yourself. So that's my story, and I want to share with you, how I've been able to incorporate my specialty lenses into, my comprehensive care practice, and share with you that these patients are there even within your comprehensive care practice. Like Dr. Kramer was saying, is that there's lots of opportunities just with, regular high ametropia, and then certain population-based, certain demographics have special requirements that they see better out of the specialty contact lens. So here's a picture of just my practice, and then, my team. And then I do see a lot of pediatric patients. That's actually a fair amount of my specialty lens, within my comprehensive care base is pediatrics. And so that's a really big place where you can actually grow your niche. So, when we were putting together this webinar, Dr. Wu actually posed, some of these questions. How do we start incorporating, these specialty contact lens patients when you have a busy, comprehensive practice? What are the things that you need to do first? How do you gain patients at first? And then finally, how do you schedule if you already have a busy comprehensive practice? So one of the first things, which I think, Dr. Wu and Dr. Kramer really emphasized within their lecture, is the first things that you need to do is really immerse yourself into learning. The way that I did it was through residency, and then through a secondary fellowship at a hospital-based setting. But you don't necessarily have to do that. Doing an apprenticeship with another doctor, if they're kind enough to be your mentor, is a good way to start. And then immersing yourself, within books. There's lots of books out there that will teach you the basics of specialty lenses. Also going to meetings. This is very important. And then pulling out, when even after my residency, I still, was trying to grasp things about basic optics that I had, dumped my second year of optometry school, and then also corneal physiology, and then corneal disease. I actually took out notes from optometry school, and I started reading all of these. It's just to really immerse yourself, within self-study. I think that is the most important thing before you get started, just to commit that you're going to understand how to see these patients and how to take care of them properly. That's very important. And so the next question is how do you gain patients at first? So, it's very interesting. As my practice has grown, I had first an associate who saw my comprehensive care patients, and now we transitioned we transitioned to another associate where she's seeing my comprehensive patients, but I'm also teaching her specialty contact lenses. And what I've done to be able to do this is that I've actually taken on more comprehensive cases, and then allowed her to shadow, and then, help me out with my medical or my specialty contact lens patients. And in this time, within this very short time, I actually started this transition in January. Is that I've seen these comprehensive patients, and within just my comprehensive patients that I've been seeing more of within the last 3 months, I've actually found specialty lens patients who have been in my practice actually 2 years or longer, who could have been transitioned over to specialty lenses, that I have, started them into specialty lenses in this short amount of time. And I just want to share, a couple of patients. I'm going to share some cases here to show you examples of how you can find these patients, because they're actually already there. You just haven't learned how to recognize it, or you will learn how to recognize them and care for them. So what's really interesting is that, I'm always attending lectures and webinars, and something my good friend, Dr. Clark Newman in Dallas, said was The difference between an expert and a non-expert is the expert knows what they're looking at. And so these patients are here. You just have to learn how to recognize them. I don't know, maybe some of y'all guys are too young to remember the movie from the Matrix, but sometimes, I'm talking to my business manager. I just feel like when I look at things and I just feel like I see things in a different way, the Matrix star did, is that he can see things, and I feel like I see things, and once you see these things, you'll start to appreciate them, and you'll start to learn where you can offer specialty lenses. So I want to go ahead and share, the possible patients that you are going to, be able to transition in your current practice, that are already part of your comprehensive care practice. And these patients are high ametropes, those patients who have degenerative myopia or high hyperopia or high astigmatism. It's really common here. I'm in San Antonio, and we have a high Hispanic population base, and seeing more than 2 diopters of astigmatism, sometimes I'll see 6 or 8 diopters of regular limbus to limbus astigmatism, is completely normal, is that these patients see much better in some sort of specialty contact lens design. And our presbyopic patients, there are so many presbyopes who are unsatisfied with the quality of vision in, a soft contact lens that has fixed parameters. They're just not able to see, what they feel like they need to see throughout the day, and they could be helped with specialty contact lenses. We already mentioned pediatrics. Is our patients, I have a big referral base from the pediatric ophthalmologists, because all the kids who see pediatric ophthalmology have really high refractive errors. And so I've been lucky enough to get those referrals. And so within them, there's a lot of patients with high astigmatism, degenerative myopia, but then there's also myopia management. I firmly believe that we should all be practicing myopia management, every single one of us who are providers. And if you don't know how to, or you don't feel comfortable incorporating myopia management, is that you should definitely refer out, because it's the best thing that you should do for the future of these children. There's dry eye patients, so many patients with, recalcitrant dry eye who are not as responsive to topicals, and who don't see well, and they could be helped with specialty lenses. There's post-refractive patients, even your LASIK patients who have, been treated 10, 15 years ago. They are regressing back to, a refractive area, or becoming presbyopic. They don't want to wear glasses. That's the main reason they spent thousands of dollars to get refractive surgery, is they do not want to be in glasses. They want to be in contact lenses. And so this has been a really large part of my comprehensive patient base that I've been able to successfully transition over to specialty contact lenses. And then other irregular astigmatic patients that you will learn to see, and I'm going to share a case with you next, and you'll start to learn to see these patients. They're there, and once you start to study, is that you will start to see these patients, recognize them, and you'll be able to manage and treat them with specialty contact lenses. So I want to share my first case presentation. This is a patient that actually has been in my practice for the last doctor that bought the practice owned the practice for 20 years before I bought it. And this patient has been a patient of the practice since she was age 5. And so she's a high myope. And at age 25, Dr. Davis had referred her for LASIK surgery because she had such a high prescription. She hated wearing glasses. So she got LASIK surgery at age 25, and she had a significant amount of myopia and astigmatism. And she's noticed within the last 2 years, I didn't actually saw her first year when I bought the practice, but I didn't see her afterwards. And she was fine with just a low prescription. She was seeing well. But within the last 2 years, she's noticed, increasingly blurrier and blurrier vision while she was driving at nighttime. And she was given a spectacle prescription by my associate in December, and she bought them. She actually bought them at an outside optical. And she's like, these glasses don't work. I see horrible. I see just weird and distorted. You know what? It's been too long. Dr. Frogrozo, since I've seen you, I want to go ahead and see you again and be on your schedule. So I went ahead and I saw her and I did her fraction, and it's nothing very it's nothing that's very recognizable or exciting to look at, just a myopic astigmatic refraction. And if you're just going through turning the wheels, the patient can see 20/20. You could force her to see 20/20, but if you really question what she was seeing, she actually reported, I see this, but everything is double. Everything starts to double at about 20/40 in my right eye and 20/60 in my left eye. I can see it. If you're asking me what I can see, it's blurring, it's vignetting. She was telling me she was seeing double and shadowing, and it was completely inconsistent. And so I went ahead, I said, okay, well, let me go ahead and look at your cornea. So, well, first we did a corneal topography, and you could see here that, she has LASIK surgery, and you could tell she's incredibly oblate. So that means they lasered a lot of tissue. And I went ahead and I really took a look at her cornea on white light. You couldn't see very much, but I thought, something just looks a little bit funny. And so I actually stained her. And when I stained her, I saw this negative staining of flat striae. And so right in the middle of her visual axis, her right eye greater than her left, she had these striae that my associate had missed. And I know that they weren't there the first year. Her mom is actually a longtime patient of mine. Her mom has keratoconus. And so, it's really interesting is that I'll see patients who are post-refractive and their topographies look, like normal post-refractive patients, but they will complain of like central glare and blur, and they'll be referred by their corneal specialist, and they say, even though the topography looks that certain way, is that I'm sure that they have ectasia. And so what I think, even though her topography, that was a most recent topography of hers, that I think that maybe her stroma in the periphery is starting to remodel, and it's creating, more peripheral steepening, which is causing her flap to collapse down and create these striae. And so that's what was bothering her vision. These patients, who see 20/20 and they're bothered, I see double, I see blurry, is that if you look a little bit harder, you can find this. And I've seen this, something that's similar to this is actually basement membrane dystrophy, the most common corneal dystrophy. I say, if I see like 10 patients a day, for sure I'll see at least 2 patients with basement membrane dystrophy. And I have a subset of patients who will tell me that they see double, and then if you look really, 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 really closely, you will find, some sort of corneal, you can find a corneal anomaly that can be helped with specialty contact lenses. So at that time, we diagnosed the problem is that she had, flat central corneal, basically central corneal opacities, which is, a medical diagnosis that can be billed towards, medical or even vision plans towards visually significant, to help her vision, visually significant medical contact lenses. And so we already know that there's LASIK complications. It's well stated in the literature. These patients, lots of patients have glare, halos, and double vision. I have, actually have a few patients who have left other practices because their doctor has told them, they tried to fit them in soft lenses or just regular contact lenses, and it told them that they saw great. They were seeing 20/20 and that there was nothing they can do more for them. And my patients told them that they felt like that the doctor thought that they were lying and they're malingering, and they're not, is that these patients have problems, and I've refitted them into hard contact lenses, and they tell me, gosh, Dr. Frogrozo, that is so much better. Thank you so much. They're so grateful. So if they're complaining, don't dismiss them. They are definitely having concerns, and just do a GP lens over refraction. Even if you don't have a scleral lens set, put a corneal GP lens on, and you'll discover is that they are telling the truth, is that they're having significant significant problems from their irregular astigmatism. So again, we know that that scleral lenses are very helpful, fixing refractive error conditions. I really like fitting them over my LASIK patients because the patients that do have significant problems are incredibly oblate. And I know that there's some reverse geometry soft lens designs, and you can try a corneal GP lenses. You could do a little bit better if you have custom software to create an oblate design, but I still find fitting a scleral lens on an incredibly oblate eye is really a slam dunk. It really helps the patient. They see better, they feel better. So this is actually what I did, on this particular patient, is that we went ahead and we went, I started off with a 16, but I ended up in an 18, millimeter lens. These were the parameters. And I got a really, really high minus over refraction because of the vault of the base curve of the lens, and then just her axial length of her eye. And so I thought, well, I have, the technology. You could leave it here and create this lens, but I have the technology in my practice. I have a scleral profiler. And the way that I use a scleral profiler in my practice, I don't necessarily use it to cut down on chair time. I actually have learned how to streamline my diagnostic fits. In my practice, I actually think the scleral topographer and my thermometer, in my practice slows me down because my techs are then bogged down by it. But when I do use it is to create really oblate designs. And so instead of having a lens that's like a minus 15, what I'll do is I'll cut the base curve down, is that we can create an oblate lens, cut it down, 5 diopters, even 10 diopters in some patients. And instead of the lens being minus 11, you can go ahead and create a lens that's a minus 5 or even a minus 1. Increase the size of that optic zone, open it up to decrease, the flare and glare from such a small optic zone and a high power, and create a really nice, lens and a more breathable contact lens. And so that's what we ended up doing on this patient. And I'm actually about to see her back next week for a dispense. But when I put that lens on, is that she said immediately better, is that ghosting and that weird vignetting that she was seeing had just disappeared. So when we saw her back for her contact lens fitting, the second visit. And so that's just one patient that I saw within the first month of me taking over more comprehensive patients. Here's a second patient that I saw. This is an active young myope, 12-year-old female who was interested in contact lenses for the first time. And my associate saw her, and she was an active dancer, so she really wanted to get into contact lenses. And so she, typical refraction, high astigmatism is totally normal here in San Antonio, regular astigmatism. And we fitted her into some molded lenses, my associate did, and said, see you later. I'll see you in a year, come back. And so then I saw her 6 months later. I saw her actually probably in February, and she had progressed a whole entire diopter. And at that time, I went ahead and I did an axial length measurement. We have an A scan in our office. It's not requirement to do myopia management, but in some patients, it does surprise me that they will actually progress in axial length, but not necessarily in refractive error. So I like to have it, just to get a definite baseline, and then also to know to be how aggressive, I treat my patients, is that if they're a high axial myope, I may consider doing, even a higher add, or even adding, a secondary atropine drop option. So you can see here in her right eye, both eyes, she's a myope, and she's, near axial length, 25 in both eyes. So at 26 millimeters, she's considered, a high myope, and almost a high myope in the steep meridian. She's close. She actually is 6 diopters in her right eye, and then her left eye almost 6 diopters there. So again, myopia management, I really feel very passionately and strongly about this because I'm a high myope. I'm a -7, and I actually progressed until I was 26. I was that subset of population that even progressed in college age. I progressed 2 diopters in optometry school. And we now recognize, hopefully everyone has started to recognize that myopia is just not a plain regular refractive error. It is a disease. You're not just burdened by these, unsightly spectacles. but it does cause, problems in the eye, and macular degeneration. It causes glaucoma, causes retinal detachments. All of these run much higher risk, the greater increases in myopia. And now there are specialty contact lenses that can help retard the progression of myopia by 50%, by causing rays of light to move more forward in the retina, and creating a cue to retard axial length growth. So there are, molded soft lenses that are available, but there's actually, specialty, soft contact lenses that you can create. And then you have to remember, even though most of the literature is on, molded soft lenses, is that what the optics what the optics that actually retard myopia is actually that center distance design. So you can actually create that on a specialty contact lens, a corneal GP lens, a scleral lens, a hybrid lens. The same kind of cue of light is also, of course, on orthokeratology, created by orthokeratology on the cornea. So all of these optics are available in specialty contact lenses. So, if you have a patient with a high astigmatism, or just has, just kind of a unique eye shape, is that you don't have to stop at just a molded regular soft lens, or a molded lens with spectacles over to correct for their astigmatism, is that you can go custom. And one thing I wanted to add is, you want to make sure that when you're going and treating these patients, that you're prescribing the right ad. As literature is always coming out, but making sure you're prescribing high ads. This is a published paper put out by Jeff Wallin and his colleagues last August that says, prescribing higher than a +2 ad is efficacious in comparison to, more efficacious in comparison to prescribing a low ad. So remember to prescribe the appropriate ad, so to retard the myopic progression. So you can see this patient, she actually has some tight lids. So it's more steeper superiorly on the topography, because she has a little bit of corneal molding from her tight lids, but she has nice regular astigmatism. Her E values are quite normal. And, I talked to mom about the option. We could do, soft custom, molded, soft custom lathe cut lenses, which I was going to go ahead, since she progressed quite aggressively, I was going to go ahead and start off with higher than a +250 ad, or we can do, nighttime contact lens wear, where she didn't have to wear contact lenses during the daytime or glasses. And mom and daughter especially found this quite intriguing. So we went ahead and we decided to do, orthokeratology lens. And so I went ahead, you can order these, lenses empirically, but especially with my tougher cases, I like to utilize software. There's software that you can get directly from the manufacturer that's no cost at all. It integrates completely into your software. Multiple companies have this. And so this is no cost, and the consultants are there to help you. So we created a custom pair of orthokeratology lenses. And then I actually saw her a week and a half ago, and this is her treatment. I put it on tangential view here, but you can see is that astigmatism is being pushed out of the way, out of her central axis. And at that time, at 2-week post-treatment, she was reporting 20/20 vision, and she said that her vision was fading at around 8 p.m. So here's another example of, where you can incorporate, specialty lenses into your already existing contact lens, or comprehensive base. So here's another patient. This patient actually found me, and this is a 52-year-old Caucasian female with a long history of corneal GP bitoric wear. And she has critical vision demands for all distances. She's actually a veterinarian, and she works on dogs with arthritis, and does house calls. And she said that it was very important to her that she saw everything good, and she did not want to wear glasses at all, because she has been wearing corneal GP lenses her whole entire life. And her typical her last doctor told her that, it's impossible. You're now presbyopic to the point where you can't, your arms aren't long enough, and you're just going to have to suck it up, and you're just going to have to wear wear glasses to correct for your presbyopia, because there's absolutely, no such thing as a contact lens that can correct for presbyopia and your astigmatism. So she's the smart lady that she is that she went on PubMed, and she literally looked up an article and to find out herself whether this was actually true or not. And she found out that it was untrue, that there are hard contact lenses that can correct for astigmatism and for presbyopia. So you have to watch out for this, is that if you have a patient that you know that you're not sure that's a contact lens, or if you're not sure about what you're able to do, but you have an inkling that it might not be true, or you think that the patient can't be helped and you don't know how, you need to be very clear with the patient that you don't know how. I tell patients, if they ask me a question, if I don't know, I tell them, I don't know, but I'm going to find out for you. I'm going to do a literature search. I'm going to call somebody who does know, because what will happen is that they will leave your practice, and then they'll tell an unhappy patient. A happy patient will tell, some, maybe one or two other friends that they're happy, but an unhappy patient's going to tell like 20 or 30 patients never to go to your practice, because you are not, you're not competent. So you need to be really careful, is that if you don't know how to manage, patients, is that you make sure that you refer out, or you try to find the answer for them. So that patient left a practice down the street and came to our practice. And so she knew that there was options, and she read them herself, and she told me what her options were. And she said, I want a bifocal contact lens or a trifocal contact lens, because I look at, small things throughout the day. I'm working with, special instruments. My patients are at this kind of odd working distance on the ground, is that I need to have all working distances. And so I want a segmented trifocal. She told me already what she wanted, which, is actually not uncommon with, specialty contact lens patients, is that they'll do a lot of research, and they'll have an idea of already, what is out there. So you have to be prepared, and you have to be knowledgeable if you're going to see this patient base. And so if you look here, taking a look at her refractive error, she does have a whole lot of astigmatism, and this is all normal. San Antonio, normal limbus to limbus, regular astigmatism, and it's approximately, more or less, the same as her refraction, maybe just a little bit of residual. And so what we ended up creating was a CPE, a cylindrical power effect bitoric lens. And you can do this by, going on a lens calculator online, which is completely no cost, or asking a consultant to create this lens for you. And the front surface, we went ahead and we did a segmented design, a trifocal, where we went ahead and we customized the measurements of her palpebral fissure, and we made it to fit her, exactly. And she saw 20/20 at distance and near, adequate, intermediate distance for her, which was, the length of where her patient sat, on the floor when she's seeing them. And then also she could read all of her special instruments. They gave her the special readings up close. So very happy patient. She's been a patient of mine for the last 2 years, and she also actually has glaucoma. And so now I manage her glaucoma too. And so very, very happy patient, regular, comprehensive, patient that is able to be in a specialty contact lens. And so here's another patient I wanted to share with you, another high astigmatism patient with dry eye. So he actually came in because he was actually suffering from his dry eye. He was told by his allergy specialist that he had dry eye. So he found us, and he wanted his dry eye treated. And he happened to mention that he also, was he rode a motorcycle, and he wanted to be able to ride his motorcycle without his dry eyes affecting him. And he wished he could wear contact lenses, but his most important thing was that he wanted to treat his dry eye. So that's what he came in with. We went ahead and we did a dry eye workup. You can see here his OSDI is 21, which is, more mild to moderate dry eye. But he did have, a rapid tear breakup time. He had some corneal changes. And so we also happened to refract him because he wanted a refraction at that visit. So I went ahead and I did that. And you could see he's got high astigmatism and also myopia. And so regular, again, astigmatism, and very, very common again, and where from my part of the world, regular limbus to limbus astigmatism, high astigmat. And so for this patient, we went ahead and we started him on dry eye therapy, but he was really interested because he knew that I also was a contact lens practitioner and specialized in that. And so he asked about contact lenses. And I said, it's not that you can't wear contact lenses, is that we have to treat the problem first before we go ahead and we initiate contact lens wear, or we have to get it as in control as possible. So I told him about the two options. As I told him about, GP lenses. So GP lenses do not dehydrate, unlike soft lenses, which he had problems with. Soft lenses are prone to desiccation and dehydration. Once they dehydrate, they don't fit well, so they can fall off, like he was complaining. And the optics are poor. If that lens is wrinkled up, even in a small kind of way, is that their vision is going to be blurry towards the end of the day. So GP lenses are not prone to desiccation, and even in a lot of cases can help and treat therapeutically, dry eyes. Like Dr. Kramer was saying, you can treat severe dry eye patients like Sjogren's and graft versus host disease patients. But, a lot of just regular patients, regular refractive high amyotropia patients who have, iatrogenic dry eye or just, dry eye because of maturity or because of hormones can specialize. You can put them into a specialized contact lenses, and then they will be willing to invest in that, completely out of pocket. So scleral lenses, we know, can actually, it's an optically active device. You can put the refraction on it, but it also is a treatment for dry eye. So I educated him about that option. And then I also told him about orthokeratology, is that if you can't wear a contact lens during the daytime, so you can wear a contact lens at the nighttime, you don't have to worry about dryness or desiccation at all. And, it's really interesting is that there is, just small literature out there, small amount of literature out there is that, with patients who do orthokeratology lenses in comparison to soft lenses, is that they report, better, comfort, a much greater or a lesser, OSDI score in comparison to a soft lens. So if you have a patient who you can't fit into a soft lens and they're complaining of their dry eye concerns, is that orthokeratology is a great option. So his assessment and plan for that day was we went ahead and we treated his dry eye, and we talked to him about his specialty lens options, and he was going to return in a few weeks. And if his meibomian glands didn't look any better, I was going to consider doing, a heated evacuation of his meibomian glands, and, to consider contact lenses in the future. So we went ahead and saw him back, and we put him on these topical therapies, and his OSDI was much better. He reported much better comfort. His eyes were very, very comfortable at this point. And he told my staff, he's like, I want to do orthokeratology. I read up on this. This is what I want to do. So we went ahead and we initiated his contact lens evaluation that day because his OSDI had went down. His surface looked better, and so I went ahead and I used another software design and I empirically ordered these lenses based on the measurements that I got from my previous examination. So this is him 3 months post-treatment, is that you can see that he is very well treated. He sees well in the daytime and then also at nighttime. And so I do have one more case, but I'm going to go ahead for the purposes of time. I'm just going to go ahead and skip that. And then we're going to go ahead and go to, some of the other questions that Dr. Wu had posed while we were coming up with this lecture is that, how to provide that the level of care to these patients, when you're incorporating them into, an incredibly, busy practice is, scheduling is actually a really important thing. So this is something that I'm still constantly working on and changing. I actually changed my whole scheduling infrastructure of how I see patients actually last month. But you want to make sure that efficiency is a key in a really, really, really busy practice, is that you want to make sure that your comprehensive patients are seen, within, they're used to being seen in 20 or 30 minutes or less and getting out of there. So you need to maintain that, but then still provide the level of care to your specialty contact lens patients, which, you need, a lot of times more time than typical. So scheduling is very big key into making this successful, and then also, successful with your patient base, happy patient base, but then also, bringing in the getting back the investment that you are putting into these patients. So in my practice, all of my exam slots are exactly the same time, whether they're a specialty contact lens patient or a glaucoma workup or a dry eye workup. They're all the same. And I've just learned through my practice to get efficient is at first you may need to build some time while you're learning, and you may need to block off larger amounts of time. But I've gotten to the point where I have my staff help me, with a lot of my comprehensive patients and my specialty lens patients. My technicians are not just typical technicians. My technicians know how to run all the instruments. They know how to base even analyze them. They'll tell me already this patient has, it looks like they're at risk for glaucoma, or they've got large nerves, or there's something, goofy going on with their macular OCT. They know how to look at the scans. They know how to fill out charts with the appropriate HPI and chief complaint. They know, the medical codes, the 99 codes and the 92 codes, what needs to be filled out, which is very important. If they can, fill that out before they get into the room, that's great. We have software to incorporate some of this so that we can take history, on the front end, so that we don't have to worry about this in the exam lane. All of my technicians refract. They know how to refract with contact lenses on and without contact lenses, sphere and SIL. So I've let that go. And they really help streamline my comprehensive care patients, where I just go in and they're already, either dilated or they have an optos done, and I go in and I just bang them out. So if my specialty lens patient, can take up, if they're in a 30-minute slot and I need, 40 minutes for them, then I can utilize that. Is that I'll take advantage of that they can help me see, these patients. So a lot of our specialty lens patients, we've already mentioned, like Dr. Wu was saying, is that she's seen, macular holes. It's not uncommon that our specialty lens patients have multiple problems. They have dry eye, they have glaucoma. And I will tell them, look, we need to do these on other visits. Your insurance or what we're billing today, or I only have time in my time slot to do your medical contact lenses today, and that is all we're going to do. I'm not going to refract you for glasses today. We're just going to do your medical contact lenses. We're going to do your glaucoma evaluation later. I'm going to refer you to my associate, where she's going to do your dry eye workup. So I make sure that our exams are completely oriented towards a problem, because really quickly, if you start addressing too many things, and you want to, because these patients need help, it could be a really big time suck. So you need to make sure that you are, at least I think that if you can address the one problem at a time instead of trying to do everything. And I've learned from my mistakes. I used to do this, which used to increase my chair time dramatically, is that you need to make sure that you're seeing everyone efficiently, because it makes the patient happy. It makes you happy because you get a lunch, and you get to get home on time, and your technicians and your staff are happy because they get lunch and they get home on time. So other pearls of efficiency, we've already talked about technology. It's nice to have this technology if you have it, but you don't necessarily need it. I do not use a lot of technology on my scleral lens fittings. I actually do I like to do most of my fittings diagnostically, and I only do an OCT because I believe that it is standard of care, and I am audited a lot because I have high volume medical contact lenses, and I feel like that it shows that we're putting in a whole lot more work if I do these special tests. But a lot of times I was taught, 10 years ago to fit scleral lenses. We didn't have that technology. So and once you get really good, is that your diagnostic fitting is actually much faster than technology, because you're not bogging down a tech who could see another patient and get them off your schedule. If you can do as much information intake in the beginning, is that get previous exam charts from doctors so that you know what the patient is coming in for. And some of these patients also, a lot of time will be taken up because they're asking you about pricing of things. Is that if you have all the information on the intake, then you can go ahead and have somebody talk to them about their financial commitment, and then that will be done. You don't have to worry about that. And then also pulling all of your insurances ahead of time, because what you don't want is you don't want to start something and then all of a sudden find out that they don't have insurance coverage, which I've done before. So just making sure that everything is available to you on the intake. So that's it. With my presentation. If you build it, they will come. This is Field of Dreams. I honestly believe that if you love it, you put passion to it, and you want to make it work, I promise you it will happen.
Well, thanks, Dr. Frogrozo. That was such an amazing presentation. I loved all the case reports. I just really think it goes to show that you can incorporate specialty lenses into a regular private practice. I mean, that's what you've done and you continue to do. And I think anybody listening that has a passion for it, just like Dr. Frogrozo has said, if you build it, they will come. So as we get to the next presenter, I have a few questions I'd like to ask you, Dr. Frogrozo, if you don't mind. The first question is, can you repeat what you said about orthokeratology related to dry eye?
Yes, yeah. So you can fit orthokeratology on patients who don't do well in soft lenses. So I have a subset of patients where they have tried soft lenses and they just can't wear them because of discomfort. And so there are actual articles that show that, putting patients in, orthokeratology lenses, they'll be able to see well uncorrected during the daytime, and they don't have to worry about, the dry eye symptoms from contact lenses. Contact lenses, let's face it, soft lenses cause iatrogenic dry eye. It's well known in the literatures that they can contribute to meibomian gland dysfunction. So taking them out of daytime lens wear, will help, a lot of times help with their concerns. And, that particular paper actually showed an increase in goblet cell function. Which I thought was interesting, is that it may even help dry eye, ? It definitely takes iatrogenic dry eye from daytime contact lens wear out of the equation.
Definitely. That's an incredible pearl. And I think it's something that a lot of people don't know about. This is a great question. I get this all the time. I'd love your comments, Dr. Frogrozo, but I am a recent graduate, and it seems like we're learning all about specialty contacts, all the different types during school. And it seems like scleral lenses have become incredibly popular and are taking over. Can scleral lenses do it all, or is there a place for some of these other types of contacts?
No, scleral lenses can do a lot. They're amazing devices, but it's not everybody's cup of tea. Is that some patients have concerns with handling, and they can't insert such a large lens. And some patients, there's a large subset of patients who are in corneal GP lenses, and they will not. I tried to actually refit a corneal GP patient who was very happy in her corneal GPs into a scleral lens, 2 of them, and they stayed in their corneal GP lenses. Is that there's still a a need for them. And, there's still a need to understand how to fit them. Because in my opinion, knowing how to fit a good corneal GP lens, that is actually the basis for every single lens design: orthokeratology, scleral contact lenses, even soft contact lenses. And so understanding how to fit that design and the ins and outs of it will actually expand the knowledge base on all of the other more difficult larger lens designs. So don't just drop that one off, please.
Yeah, that's something that I think a lot of students and practitioners really need to hear, is that scleral lenses, they are amazing. I obviously, all four of us on this panel love them when you use, and we use them a ton, but there is definitely a time and place where you can use them, where you can't. And sometimes even with safety, some of the corneal transplant patients that I have fit have kind of taken a turn for the worse with scleral lenses, and so it's a safety issue for some of the patients. So I really think that if you know how to fit corneal GP lenses really well, it is a major advantage and a leg up on a lot of other maybe competing practitioners. I have another question that was for you, Dr. Frogrozo. When you're having a regular comprehensive clinic, and you have a patient, let's say they have presbyopia and they've got astigmatism or they've got some other issue, how do you have a conversation with a healthy patient about specialty contact lenses?
Sure. So you tell them that the regular contact lenses out there are fairly good, but because you have a complex prescription, you're just going to see much better in a lens that's more customized for you. When I look at your corneal topography, I can tell by your eye shape is that you're going to be able to see if I go ahead and if I make the diameter larger. So in a lot of my patient base is that their HVIDs are actually larger. They need, steeper lenses. I can tell that, is that we could probably get a regular soft lens on your eye, but you're most likely going to see better in a specialty contact lens. And so it's definitely well worth the investment, especially if you want to be out of your glasses consistently most of the time, out of your reading glasses most of the time. So you just have to educate them about what's out there. And if they choose, a typical lens design, that's fine. Let them experience it. And then, then you can share with them the customization if it doesn't work out.
Yeah. And you mentioned some of the orthokeratology designs in your presentation, and somebody had asked, do you know which orthokeratology designs are empirical?
So all of them, you can actually send your topographies and your spectacle prescription. If you don't have you should, okay, let me back up. If you don't have a topography, you should not be fitting orthokeratology lenses, but they go off of Ks and they go off of refraction. But to make sure the treatment is going the correct way, and that to troubleshoot, you have to have a topography. So you can order baseline lenses off of Ks and refraction, but you need a topography in order to follow the patient. So all the lenses are actually empirically ordered. I'm just now starting to dabble in complete customization, which another doctor in Italy is helping me do, that I'm now starting to look into. So I'm still doing some empirical, and I'm just now starting completely customized.
That's incredible. I know the technology. I mean, I remember when I was a resident, when we did our residency, and I remember we had that giant fitting set of the diagnostic lenses for Ortho-K. And I was like, okay, using the little calculator, figuring out which lens to put on. And if it didn't fit perfectly, now what do we do? And now it's like, that used to kind of be the gold standard, was using these fitting sets in the office. And now it seems like almost all of the companies have some sort of empirical design. I mean, it's just within just like 10 years of the advances in technology. So one last question for you before you move on to the third section of our series. If you wanted to integrate a specialty lens practice into an existing clinic, that is heavily based with Medicaid type patients. Is that possible?
So I would say anything is possible if you put your mind to it. Is that it is challenging because Medicaid does not cover any specialty lenses or any contact lenses at all. So you have to, make sure that you are trying to integrate this, but understanding the patient, not to lose your regular patient base. Your patient base is going to turn into a different kind. You'll have your Medicaid patient base, which you enjoy seeing, but bringing specialty lens patients into your practice will morph it into something different. Well, you'll start to see other plans where you'll find the need to accept other medical plans and other vision plans in order to accommodate your patient base. So I still see my comprehensive patient base. There's still that large population of glaucoma patients that the last doctor left behind the legacy, and I still see them. But now I've brought in completely something different, and my patient, my infrastructure has changed. His infrastructure is still there, but it's now, with mine incorporated. So you'll see your everything will morph. If you want to still continue to see Medicaid, which, is a very, difficult population of pediatrics, I think you should still continue to see that, just to make sure that you can still, see those patients, but then try to build room to incorporate your new growth for specialty lenses as well.
Great. Well, thank you, Dr. Frogrozo, for all of your insights. Such an amazing story that you have. I love learning from you, and the fact that you are one of the very few that went out into practice and then said, no, I'm going back. I'm doing a residency because this is something I love. That's truly inspiring. So thank you for sharing your story. We've got other questions for you, and I hope that you'll stick around at the end for a few other questions from the audience.